Welcome back everyone. In today's video, we will continue with the treatment of depression. In the previous video, I went through an overview of clinical depression and explained the first generation antidepressants. Before we start with the second generation antidepressants, I need to mention the monoamine hypothesis of depression. Serotonin, dopamine, and norepinephrine are called monoamines because they have one amine group in their structure. This theory happens when the monoamines are present in less than the normal amount. The reason as to why this decrease happens is unknown, but the fact remains: less amounts of monoamines leads to symptoms of depression. On to the second generation antidepressants. The second generation antidepressants were introduced during the 1970s and the 1980s. These drugs include selective serotonin reuptake inhibitors SSRIs, serotonin and norepinephrine reuptake inhibitors SNRIs, and other drugs with a related mechanism of action that target the monoamines, like the dopamine norepinephrine reuptake inhibitor DNRI and the noradrenergic and specific serotonergic antidepressant. Starting with the selective serotonin reuptake inhibitors SSRIs. SSRIs selectively block the reabsorption of serotonin from the synaptic cleft. This leads to prolonged exposure to serotonin, leading to a better mood. Examples of serotonin reuptake inhibitors are citalopram, sold under the brand name Celexa, escitalopram, sold under the brand names Cipralex and Lexapro, paroxetine, sold under the brand names Paxil and Seroxat, fluoxetine, which you know from its brand name Prozac, fluvoxamine, sold under the brand name Luvox, and citralline, which is sold under the brand name Zoloft. A way to remember these is by cereal puffs. So cereal has C, citalopram, and E is citalopram. Puffs has paroxetine, and F for fluoxetine and fluvoxamine, and finally S for citralline. SSRIs are taken once per day, usually at night because of their sedating properties, but fluoxetine is taken in the morning because it can make some people feel more energized. SSRIs are the first-line treatment for depression, and the majority of people will only experience few mild side effects when taking SSRIs, which makes it the drug of choice in treating depression. And the common side effects of SSRIs can include blurred vision, dry mouth, insomnia, drowsiness, headache, loss of appetite and weight loss, sexual dysfunction, and orthostatic hypotension, which happens when you get dizzy when you stand up or sit up after laying down for a while. Serotonin and norepinephrine reuptake inhibitors, SNRIs, are the second type of second-generation antidepressants we'll be talking about in this video. SNRIs work by blocking presynaptic serotonin and norepinephrine transporter proteins, which inhibits the reuptake of these neurotransmitters and leads to increased stimulation of postsynaptic receptors. Examples of SNRIs are desvenlafaxine, venlafaxine, which is also approved to treat certain kinds of anxiety disorders and panic disorder, duloxetine, which is also approved to treat anxiety and certain types of chronic pain, levomilnacipran, and milnacipran. A way to remember SNRIs is DVD-LAME. D, which stands for desvenlafaxine, V, venlafaxine, D, duloxetine, so DVD, and LAME, which stands for levomilnacipran and milnacipran. Side effects of SNRIs include dizziness, dry mouth, insomnia, headache, nausea, constipation, loss of appetite, and sexual dysfunction. A few things to note is that venlafaxine may raise the blood pressure of a patient, especially if the dose is more than 150 milligrams per day, and duloxetine may worsen liver problems. And now we're going to talk about the dopamine and norepinephrine reuptake inhibitor, Bupropion. Bupropion is used in the treatment of major depressive disorder and smoking cessation. It works by blocking the reuptake of dopamine and norepinephrine from the synaptic cleft. The side effects associated with the use of Bupropion are dry mouth, insomnia, headache, nausea, vomiting, weight loss, and seizures. Mirtazapine, which is also known by its brand name Remeron, is a noradrenergic and specific serotonergic antidepressant. A significant feature is its effect as a histamine 1 antagonist. This antihistamine effect is linked to sedation and weight gain side effects. Adverse effects for mirtazapine include sedation, weight gain, constipation, dry mouth, and increased appetite. Choosing an antidepressant depends on the patient. Typically, the benefit of antidepressants outweigh the possible side effects, So which antidepressant is best for the patient depends on so many factors, such as other health conditions, patient preferences, costs, and side effects. For example, is our patient depressed and trying to lose weight? Bupropion is our medication because it helps in losing weight. While on the other hand, if we have a patient with a history of seizures, bulimia, or anorexia, bupropion is contraindicated. If our patient is having trouble sleeping and also trying to gain weight, then mirtazapine is our answer. If our patient has peripheral neuropathy and or musculoskeletal pain, then using duloxetine is the best of both worlds because it treats both conditions. Serotonin syndrome is when the serotonin levels become too high in the brain. This causes confusion, twitching, agitation, sweating, high body temperature, arrhythmia, irregular heartbeat, seizure, and loss of consciousness. Serotonin syndrome can happen when a patient is taking an SSRI in combination with another medication or drug that either increases serotonin formation, such as tryptophan because it's a precursor of serotonin formation, increases the release of serotonin into the synaptic cleft, such as amphetamine, inhibits the reuptake of serotonin from the synaptic cleft, such as tramadol or St. John's wort, inhibits serotonin metabolism, such as a monoamine oxidase inhibitor, is a direct serotonin agonist, such as bupropion, increases the sensitivity of postsynaptic receptors, such as lithium. In conclusion, SSRIs present medication or substance that raises serotonin level means serotonin syndrome. Now you're probably wondering, how do we treat serotonin syndrome? The first step is to discontinue the medication immediately. We have to monitor the body vital signs, and if the patient is agitated, we have to administer benzodiazepine. If benzodiazepines fail to improve agitation, we need to administer cyproheptadine. With this, we reach the end of the video. I hope you are all happy and healthy. Comment down below what other topics you would like to hear about, and thank you so much for watching. Until next time, stay happy and stay healthy.